Head and spine trauma. Head and spine trauma accounts for probably 25% of traumatic injuries in the United States. These can be some of the most debilitating injuries that patients will experience, life-altering injuries not only for patients but for their family members. The care that we provide in recognizing head trauma and treating it properly, providing rapid transport to an appropriate facility can have a major impact on the not only our patients' survival but their long-term well-being. It's important to understand the anatomy of the brain and spinal cord, to understand the physiology of the brain, the spinal cord, and to understand the pathophysiology of injuries to the brain and how we treat those, knowing that there are times when we do everything textbook perfect. Things couldn't have gone better from an EMS perspective, and these injuries still have catastrophic results for our patients. So let's dive into the anatomy really quickly, hit a little bit of the physiology of the function of the central nervous system, and then we'll move through some injury and treatment. I will divide the lecture into the head trauma portion and then the spinal trauma portion. That hits about halfway through the material. As we take a break after head trauma, I will send you a link to a new session for spinal trauma. That allows us to post two separate videos, which will make it more manageable on YouTube and maybe give you something that's a little easier to use as a tool. With that said, let's keep moving. The central nervous system is comprised of the brain and spinal cord, and within the spinal cord there are millions of nerve fibers. Within the entire body there are billions of nerve fibers. Haven't counted them, but I'm quite sure that that's close enough for me. The brain is protected by the skull. After the brain exits the foramen magnum at the base of the skull, that begins that proximal portion of the spinal cord we call the brain stem, and from there the spinal cord extends the full length of the spine, and full length of the spine. The spinal cord is protected by the vertebral bodies, which would be the bones that are stacked up making up the spinal column, the cervical vertebra, the thoracic vertebra, and then the lumbar vertebra. Below that we have the sacrum and the coccyx. The spinal cord does not extend down to the sacrum and the coccyx. As nerves exit down in the lower lumbar spine, that branches out into a nerve plexus that innervates those distal areas. And then there's muscular protection, there's ligaments, there are extensive structures making up the spinal cord. There are, within the skull, there are protective layers that we'll talk about in a few minutes, as well as cerebrospinal fluid Uh, some of us have an extremely hard cranium. My wife would tell you that I lead the pack on that one. She wouldn't be wrong. Uh, Despite all this extensive protection within the body, serious injuries and damage can still occur to the nervous system. Divide our nerves into central nervous system and peripheral nervous system. Again, central nervous system, where'd it go? Sorry. Central nervous system is the brain and the spinal cord. Peripheral nervous system is all those billions of nerves after they exit the spinal canal, and we'll go through some of those in a minute and get a better picture of that. Here's a representation from your book. Think of the spinal cord not as one big nerve. I had that misconception for way too many years, and I may be the only one who went through 2 semesters of anatomy and physiology and never quite grasped the fact that the spinal cord is comprised of multiple nerve fibers. If you think of, if you look at the end of a cable and you see all the wires that make up that cable, that would be similar to the structure of the spinal cord. Or if you want to get a little more high tech, let's think about a fiber optic cable that has multiple fiber optic pathways within that one cable. The spinal cord functions the same way. And let's talk through a few of those structures. Within our brain, we have a right hemisphere, left hemisphere. Those are divided into 4 lobes. There are sensory areas of the brain. There are motor areas of the brain. Those link up with particular nerves as they travel down the spinal cord and exit at the level of each vertebra with a specific nerve being used to tell a specific muscle to contract. For instance, if you want to extend your arm, there's a balance of muscular contraction that allows for that smooth extension of your arm. Your triceps muscle contracts to extend your arm. Your bicep also holds pressure to balance that out so that it's a smooth movement. That can be a slow smooth movement or a rapid smooth movement, as you know. That would be a peripheral a peripheral nerve that exits at the level of a vertebra and extends down to innervate or provide a nerve connection to a muscle. We have sensory nerve endings. For instance, sensory nerves in our fingers. Think about buttoning the button on a shirt. Your sensory nerve endings in your fingers tell you that your fingers are touching the button. That sends that message back to your brain. Then motor nerves send a message down telling your fingers and your forearm how to contract and relax in order to perform that function of buttoning a button. And then there's a different type of pathway would be a a pathway involved in a reflex arc that does not include a connection to the brain. A reflex arc, I don't have that picture. Reflex arc is the interaction of a sensory nerve and a motor nerve with the signal making it to the spinal cord, for instance, touching a hot stove with your finger. Your brain doesn't have to tell you to move your hand. Via reflex arc, the sensory message goes to the spinal cord saying we just touched something really hot, and then then a message goes right back out to the motor nerve to have you withdraw your finger from that hot surface. Brain is the control center of consciousness within the body, divides into the cerebrum, the cerebellum, and the brainstem. stem. Cerebrum is the largest part of the body of the brain. You can see the lobes that I mentioned there. You have the frontal lobe, parietal lobe, occipital lobe. Tucked under that would be the cerebellum. We'll see the importance not the importance. That's a poor use of terms. We will see the involvement of the cerebellum in what's called a brainstem herniation when we get down in a minute to talk about closed head injuries. We'll talk about that in a few minutes. The effect that has on the body, and then the possible result of that. Let's see, should be a pointer there now that you can see. We'll see in a minute that this on an X-ray, actually, I believe it's on a CT scan, that right at this level where that would be the foramen magnum, where the spinal cord exits the cranial vault and begins down the channel of the spinal canal. We'll talk about the temporal lobe. We don't get in this chapter. We don't get extensively into the function of all the different lobes, damage to the different lobes from things such as a stroke, also called a cerebrovascular accident. We spent some time on that back in the neurologic emergencies chapter. So if you have questions as you work through this material regarding the function of these different lobes, that chapter that we covered before spring break would be an excellent reference for you. Cerebrum, that is this large body of the brain that comprises about 75% of the blood volume, as I said, 2 hemispheres and 4 lobes. Cerebellum coordinates balance and body movements. As we talked about in the neurologic emergencies chapter, if you have a complete neurologic assessment, say by a neurologist, high likelihood that neurologist will watch you walk heel to toe to see how well you walk heel to toe, and that provides information about cerebellar function in your body or in a patient's body for us. Brainstem, that's the rudimentary brain that controls the basic functions necessary for life. What do I mean by that? That contains our respiratory center, that contains the the areas that sense the pH of cerebrospinal fluid, which control the rate and the depth, and also the rhythm or pattern of respirations. That is the best protected part of our CNS, your book says, because our body needs to protect that to keep us alive. Damage to that area, for instance, in a patient with a hangman's fracture, a fracture subluxation of C1 and C2. Subluxation, boiled down to its bare meaning, I guess you could say, would be a dislocation, moving out of its normal alignment. So we fracture C1 and C2, we pop them out of alignment. That cuts through the brain stem, and life is over. There are times that you encounter injuries to patients in the field other than hangings that cause a hangman's fracture. It could be something such as uh, falling, trimming a tree, and and getting the chin stuck in a forked branch and causing that fracture subluxation. Uh, Really hard impact, lateral impact to the skull could possibly cause a hangman's fracture. It's also going to cause significant uh, brain trauma as well. But those things are discovered on autopsy. We don't exactly know in the field what that cause of death was. It's not within the purview of our education, and definitely not within our scope of practice as EMTs. Protective coverings. We don't just have the hard bony framework that provides protection. We Our brains also have meninges. Those are protective layers that cover the entire central nervous system, the innermost being the pia mater, the middle being the arachnoid mater, and then the hard external layer being the dura mater, durable. That's how you remember that's the toughest one. We'll talk some more about those and how those come into play in some head injuries here in a few minutes. The inner two layers, the arachnoid mater being the middle and the innermost being the pia mater, that contains blood vessels that feed the brain and the spinal cord. There are also nerves and arteries within the brain itself that supply oxygen to the brain. Just a cross section that shows brain tissue, and then this is the pia mater here that goes in and out all those folds and creases along the surface of the brain. And then the arachnoid mater is that middle spongy layer. You can see those are supposed to be blood vessels, the little red and blue circular structures. Then the dura mater, that is that fibrous, tough outer layer of protection, and then the skull, and then the layers of soft tissue that are over the top of the skull. Excuse me. Uh, circulating here in the arachnoid mater is going to be cerebrospinal fluid. Cerebrospinal fluid is produced in an area of the brain called the third ventricle. We have about 125 to 150 milliliters of CSF, cerebrospinal fluid. We'll use CSF from here on out probably. In the brain at any time. It acts as a shock absorber as intracranial pressure increases and decreases from things like if you bend over at the waist to pick something up, getting your head down, that raises your intracranial pressure. Off the top of my head, the normal range of intracranial pressure, I believe it's about 12 to 20 millimeters mercury. As that increases, our body starts to displace cerebrospinal fluid down through the fourth ventricle of the brain and push that down along the upper spinal cord through structures that are called cisterns, and that displacement of cerebrospinal fluid, displacement of CSF, is what keeps the intracranial pressure in balance. When we have increases in intracranial pressure, we have specific pathophysiological changes that cause damage to the body and can eventually cause death. We'll talk about some of those in a minute. Peripheral nervous system, we have 31 pairs of spinal nerves exiting along our vertebra, beginning in our cervical spine and then exiting all the way down, conduct impulses from the skin and organs to the spinal cord, conduct motor impulses, just like we talked about a minute ago, from the spinal cord to muscles, and pathways within the spinal cord involve our brain in the voluntary functions in the movement of the body. There are many functions that are autonomic functions that we have no voluntary control over. There's a large network of spinal nerves serving the extremities and providing information and motor movement along pathways in those nerves, or allowing for motor movement because of nerve impulses conducted along those pathways would be the better way to say it. Here's a decent representation of what we're talking about. We have, as I said, along the vertebral column, you see these spinal nerves exiting. In the shoulder, you have the brachial plexus, which is that network of nerves that innervates our shoulders and our arms. And then as we get down into the lumbar spine, the lumbosacral plexus, which used to be called the equine plexus, that's a history comment. That's nothing that would be on an exam for you, but that network exits down in the lumbar region and innervates the really from about the umbilicus down would be a decent way to put it. 12 pairs of cranial nerves. Those have specific functions in everything from smell and taste to pupillary function, dilating your pupils, constricting your pupils. What are other things? We have another chart. Those cranial nerves the 12 pairs of them, they transmit information directly to the brain. They are hardwired into the brain. Those messages don't travel along the spinal cord. Those are wired directly into the brain. There's a long, crazy chart. There's those of you who have had anatomy and physiology probably memorized on old Olympus towering tops uh, a fin, and it used to be and now it's a V, but it used to be an A. Uh, a fin in German viewed some hops, and because S used to have a cranial nerve 11, used to have a different name. We renamed a couple of them. The vestibulocochlear nerve, cranial nerve 8, that is a much better description of that nerve than the auditory nerve, which is what it used to be called when I learned it. It's involved with balance as well as hearing. Brain tumors, things such as that could put pressure on these cranial nerves and cause or like a stroke, uh, can cause a loss of smell, could cause a loss of sight, uh, could cause the eye not to move and track objects anymore, could cause paralysis of facial nerves, and on down the line. But that is those are the cranial nerves. Uh, a lot of that has to do with sensory functions of the body. The vagal nerve has sensory function, that would be cranial nerve 10, that has a sensory function in our pharynx. It also has a motor function, not as in us being able to feel something because of that nerve, but the vagal nerve is a major component of our parasympathetic nervous system. Remember, the parasympathetic nervous system balances out the sympathetic nervous system. The sympathetic nervous system, that's fight or flight. The parasympathetic nervous system, we often call that the rest and digest system. Those work in balance. If you think about the Asian symbol for yin and yang, the two things balancing one another out, that's what's going on there. That is vital for homeostasis of the body. All right, let's continue on. Sensory nerves carry one type of information uh, from the brain. Where was I headed? From the brain or to the brain via the spinal cord. Uh, that's touch, uh, touch sensation with our feet, with our hands, with our fingers. Uh, if we feel our shoulder brush up against somebody right now with COVID, holy crap, we're closer than 6 feet from one another. We have to space out. We can't be this close together. Previously, it didn't seem like a big deal to brush shoulders with someone at Walmart. Now people freak out. Don't count me amongst those who freak out over brushing shoulders. Probably been exposed to worse. Okay, motor nerves, one for each muscle. We and that carries information from the CNS to those muscles. How to make my index finger move just enough to advance to that next slide. And then we have connecting nerves within the brain and spinal cord. If you picture your brain and you have all those neurons in your brain, you have microscopic connecting nerves that connect those neurons within the brain with just millions or maybe billions of little short fibers that allow for the quick exchange of simple messages between areas of the brain. Okay. Nerves control everything our body does, from maintaining homeostasis to getting up and walking outside to take the dog out during a break in this lecture. Okay, I talked about reflex arcs. Here is the picture that I was thinking about. Here is this hot candle, the hand over that. The brain is not involved in the decision to pull that hand away from the flame. We're saying people voluntarily hold their hands in the flame sometimes. You can voluntarily fight and override that reflex to pull the hand away. Here is the picture of it. That sensory message makes it via that sensory nerve up to the spinal cord, and then it exits, then an impulse exits right back down that motor nerve, and lightning fast gets to the hand pulls away. I used to do a trick around the ambulance station until nobody would play along anymore. I'd bet people $20 that I could lay down on the table, take a laryngoscope, and show them my vocal cords. Yes, I have a gag reflex. What I was doing was voluntarily overriding that gag reflex so that I could hold that laryngoscope down in the right place long enough to show them my vocal cords. Not many people wanted that bet after I made 40 or $60 off of it. It was fun while it lasted, right? Okay. And I mentioned the sympathetic and parasympathetic nervous system, portions of the autonomic nervous system, involuntary, uh, fight or flight is sympathetic, parasympathetic is rest and digest, fight or flight. Uh, that's important to us in compensated shock. We're not running away from something, but the drop in blood pressure causes adrenaline to be released from our adrenal glands. Boil this down to its most simplistic description here. It causes adrenaline from our adrenal glands causes what? Beta 1 causes an increase in heart rate. The beta 2 receptors pick up on the beta 2 properties of adrenaline, and that causes relaxation of the smooth muscles in our airway, so that causes bronchodilation. Uh, we have causes dilated pupils. If we're going to fight or if we're going to run, we need to get the most light in possible so we can see the best that we can. So that causes dilation of the pupils, and then alpha receptors in the smooth muscles around our arteries cause peripheral vasoconstriction, and that helps raise our blood pressure. So that's sympathetic. Parasympathetic nervous system, uh, after the need for fight or flight is over, or trying to balance it out so the system doesn't run away and kill the body. Uh, the vagal nerve, the norepinephrine starts to counteract. The vagal nerve does not produce norepinephrine. Norepinephrine is also produced in the adrenal glands, and that hormone causes that counteracts the effects of adrenaline and starts to reverse those sympathetic responses. But while we are in full fight or flight mode, that the sympathetic response is much stronger than the parasympathetic. So in compensated shock, for as long as we can compensate, as long as that adrenaline holds out, our patient is going to compensate for the shock. Then as shock persists, eventually our body can't compensate anymore. And after the body can't compensate, then our patient starts to decompensate, as we talked about a couple of weeks ago, and we'll talk about more over the next few weeks. As our patients decompensate, that's when we start to see falling blood pressure, all of that. So sympathetic nervous system uh, helps keep us alive in emergencies, hopefully until somebody like you or I come along and hold direct pressure and stop that bleeding and provide necessary oxygen and rapid transport to a trauma center. So somebody who writes MD or DO after their name can take a knife and go in and treat that surgical disease that we call trauma. Okay, skeletal system. Uh, we're not going to memorize names of bones. It wouldn't take long to memorize these, but I mentioned the cranium. That's those fused bones that provide that hard protective layer that to help keep our brain safe. And then the bones of the spinal column, those are involved in protection. Cranium, 80% brain tissue, 10% blood supply, 10% spinal fluid. That spinal fluid again it's a cushion. Spinal fluid is also important in uh, in our respiratory function. Chemoreceptors in our brainstem sense the pH or acidity level of cerebrospinal fluid. If those sensors sense that the pH is going down, meaning that the spinal fluid is becoming more acidic, then that's going to increase the rate and depth of respirations to try to eliminate carbon dioxide and bring in more oxygen to try to reverse that change. Okay. We did all this when we did that human body in a day. We talked about the skeletal system. I'm not going to spend time on it today. Why is that important to us today? We have nerves for exiting the spinal cord at each of those vertebrae and going out and innervating muscles within our bodies. Injury to a vertebra. I mentioned earlier, for instance, with a hangman's fracture, how injury to a vertebra could cause death. In moving down the spinal column, a fracture to a vertebra, injury to a vertebra that damages the spinal cord can cause paralysis, fractures in the upper cervical spine can cause our patient to be a quadriplegic, paralyzed in all extremities, and in the lower cervical spine, those fractures with resulting spinal cord damage can cause our patient to be a paraplegic or not be able to, for instance, uh, feel or move from maybe the umbilicus down. That would be uh, the very low cervical spine and proximal thoracic spine for that. Head injuries. Let's talk about those for a few minutes. These are old statistics. 52,000 deaths occur annually in the U.S. from severe head injury. That may be more, that may be less. How could it be less? More use of helmets in motorcycles, more seatbelt use so you don't have people being unrestrained in a motor vehicle collision and having their heads slam into the windshield, keeping them from being ejected in a rollover, things like that. Trauma to the brain can be open brain trauma, where we have penetration of the skull into the cranial vault and involving brain tissue directly, or we can have a closed head injury, which can be from deceleration forces, can be from a blow to the head that doesn't open the cranial vault but causes bleeding around the brain, causes pressure. That's more than half of all traumatic deaths. And then I believe abdominal trauma is 25%, 24%. Thoracic trauma is around 20, 23 to 25%, and then everything else. Like I said, closed head injury. There's no opening into the cranial vault, so you have injury to the brain without opening to the outside world. Open head injuries have an opening to the brain for the brain open to the outside world. Started to say that backwards. Sorry about that. Uh, Again, I said that could be caused by penetrating trauma, bullets, rebar, large knives, gear shifts in cars, hammers. Those are some of the things that I've seen. Uh, People always find new and creative ways to get themselves killed or to kill themselves. A bull's hoof at a rodeo stomping on a guy's head and causing an open head injury. We'll add that to the things that I've seen. MVCs are the most common mechanisms of injury leading to head injuries. Add to that victims of assault, elderly people with falls. That is a large percentage of head injuries that are comprised of elderly people falling and hitting their heads. And then sports related incidents, boxing, football, soccer. How else can you get closed head injury? It could happen in basketball. It could happen baseball, being hit in the head with the ball. All kinds of sports. And then uh, falls with kids, uh, violence toward kids. And then we could add to this list, not that it comprises a major portion of statistics in our EMS world, but traumatic brain injuries from explosions. In the military, that is IEDs, roadside bombs, conventional explosives, all of those things can cause that's a significant mechanism of injury leading to those traumatic brain injuries. Any head injury is potentially serious. Talk more about that in a second. Uh, Here is and I can't move it over so that I can even see it. If you like charts, this will be available. You have this in the PDF of the PowerPoint. available to you through Blackboard. You also will have this in the video of this lecture. If you want to endure my monotone, horrible voice yet again, you can you can search Richard Todd on YouTube, get to my YouTube page. Also posted an announcement last night with a link to that YouTube page, beginning with the 3 chapters that were on your exam today. The rest of the lectures will be available there, and they'll be available on that YouTube page after the course is over, so that you can go to those for review if you need it as you prepare for National Registry. Still haven't had time to backfill and start catching some of those earlier chapters. I will try to record at least an overview of each of the beginning chapters in the book uh, before this class ends, so that you'll have those also. Okay. Scalp lacerations, that can be the most minor of injuries to the head that you will encounter in your EMS career. It's amazing how much bleeding comes from even a small laceration to the scalp. You'll run calls that you absolutely convinced that there is an enormous laceration on your patient's scalp after a car wreck, and there's blood just pouring down your patient's face. There's dried blood all over their face, blood all over their clothes, and morbid curiosity gets the best of you if you're like me. And as you run more calls, you pop back in to check and see how your patient's doing. Really, we just want to see how big that stinking laceration was. And after they shave the hair away to get ready to suture that laceration, you look and you have a 2 centimeter laceration that uh, you were convinced was causing your patient to lose their entire circulating blood volume of 5 to 6 liters. Those are the least worrisome overall of injuries to our patients' heads. Uh, it would be very rare for a patient to bleed enough from a scalp laceration to cause hypovolemic shock. Uh, with pediatric patients, they're more likely to bleed enough from a, a scalp laceration to lead to hypovolemic shock. Someone who's on blood thinners, so we start dealing with that middle-aged and elderly population, folks who are on blood thinners maybe because they have atrial fibrillation and they're treated with blood thinners to anticoagulate them to help prevent thrombolytic stroke from occurring from blood kind of sludging in the atria and little blood clots breaking off and being pumped out by the heart. What we're more worried about with scalp lacerations are the risks that our patient may have a closed head injury. They may have a concussion. Would be of the closed head injuries, a concussion would be the least serious, ranging on up to maybe a subarachnoid hemorrhage that we'll look at here in a minute. That's a major scalp laceration. That's also a good example of an avulsion. I assure you that that bled considerably when that happened. What are we most worried about here? This patient may have suffered some significant trauma to the right frontal portion of his skull that caused trauma to that area of his brain, and we're most concerned about performing a complete assessment so that we can monitor, we can identify whether or not our patient has signs and symptoms of a concussion or a more serious closed head injury than that. We would be concerned, honestly, about an open head injury here. If we have signs and symptoms of traumatic brain injury coupled with a laceration to the scalp, that meets the definition of an open head injury. This isn't bleeding anymore. I can see the shiny periosteum or the protective layer over the top of the bone of the skull. I don't really see penetrations into the skull, but I don't have x-ray eyes, and this is just a picture in a PowerPoint. Skull fracture, that requires significant force to cause that fracture. That skull fracture can be a linear fracture that just causes more of a split to the skull. It could be a comminuted fracture. Think about a baseball bat smashing into a patient's head. That's just like breaking an eggshell. It just shatters it in that area of impact. That can push bone fragments down into the brain. Bullets can do the same thing. Claw hammers can do the same thing. Other hammers take significant force. Those would apply significant force. If we see that our patient's skull appears deformed, or if somehow we can see visible cracks in the skull, pre-hospitally, we're not going to see those visible cracks in the skull. Usually, going back to this man, if we could see a big jagged line along his skull that's opened up, or you see a shattered portion of that skull, then that would be visual confirmation of a crack in the skull or an opening in the skull. Uh, Other indications of a skull fracture, a basilar skull fracture is a fracture of that bony floor of the cranial vault. So think of the bony structure that the brain sits on there in the skull. That's the basilar skull. If you have an injury that fractures that, you see some particular signs of that. The most immediate sign of that would be cerebrospinal fluid coming from the ears, coming from the nose. So if you have a clearish, watery, sometimes red tinged fluid coming out of the patient's nose or ears, we want to do a halo test on that. You want to get some of that fluid on a piece of 4x4 gauze, set that aside, and in 5 or 10 minutes, it takes some time occasionally, you look and you can see that separating out into concentric rings. That's called a halo. As that separates out, that would be confirmation, at least for a clinical diagnosis, even though as EMTs we don't diagnose, but for our purposes, that would tell us that there's a basilar skull fracture. We'll talk about treatment of that toward the end of this lecture. If you give some time following a basilar skull fracture, let's say going to that bottom one, battle signs, first described by William Henry battle about in the late 1800s. Uh, that is a sign. It's they call it mastoid ecchymosis. You have bruising around that bony prominence that is on your skull, straight back behind the pinna of your ear, right back there. I believe we have some pictures of that in a minute. That takes around 24 hours to develop after that skull fracture. If our patient lives that long, that depends on the extent of the skull fracture and the extent of injury to the brain. And then the other sign, ecchymosis type sign of a basilar skull fracture is periorbital ecchymosis, raccoon's eyes, bruising under the eyes of the patient. There's a picture of periorbital ecchymosis, raccoon's eyes, and then right here behind the ear and going down to the mastoid process, that is battle sign. Uh, the majority of skull fractures are linear skull fractures. Those are diagnosed with x-rays. Depressed skull fractures, which I also called a comminuted skull fracture a minute ago. Comminuted fracture would be that shattering of the bone. Depressed would be pushing that bone down onto the surface of the brain. That can also drive bone fragments down into the brain itself and cause uh, direct injury and bleeding within the body of the brain. Here's a new term for you, the parenchyma of the brain. Parenchyma means the body of an organ. So your brain is an organ. The parenchyma of the brain would be the brain itself with bone fragments, skull fragments being pushed down into the brain. Basilar skull fracture, I already talked about. That's associated with high energy trauma, usually with impact to the head. We have CSF draining potentially from the ears, from the nose, because those are right in the area of that base of the skull, that the basilar skull, the floor that the skull sits on. And then, so that halo test of the CSF draining from the ears or the nose, that separating out on that 4x4 gauze. And then after a matter of hours, possibly having raccoon's eyes and battle sign develop. Open skull fracture, uh, you have an opening in the scalp, you have an opening in the skull that extends down into the brain tissue. High risk of infection with that, if nothing else. Also takes a lot of force and a lot of trauma from the mechanism of injury that causes that opening in the skull, and you have significant trauma to the brain. Okay. Primary brain injury, that's instantly from impact. You have, let's say a baseball slamming in to the temporal skull right there, you know where your temple is. Baseball slamming into someone's temporal skull, and that can instantly cause a subarachnoid hemorrhage that can lacerate the middle meningeal artery and cause bleeding. Secondary brain injury would be, let's say grandpa falls, hits his head, has a slow bleed below his dura mater and above his arachnoid mater. So within the arachnoid mater, they're toward the surface of the arachnoid mater, and blood starts to accumulate between that hard, fibrous, tough dura, and that hematoma develops. You have a collection of blood that starts to put pressure on the brain and does two things. It impairs the function of the compressed area of the brain, and it also raises intracranial pressure. And you get particular signs and symptoms that go with that we'll talk about in a minute. Those are secondary brain injuries. Other causes of secondary brain injury. Uh, Part of these would be due to hypoxia. Could come two ways. It could be from hypoventilation and what we call an anoxic insult. The patient doesn't breathe. They don't provide oxygen to the brain, and we start to have damage to brain tissue. That would be a type of secondary injury to the brain. Hypotension, so that we're not perfusing the brain with oxygenated blood and glucose. And then cerebral edema, increasing intracranial pressure and decreasing circulation to the brain. Hemorrhage within the cranium, such as what I was just describing with the subdural hematoma. Increased intracranial pressure that eventually prevents blood flow to the brain. Cerebral ischemia, that's a better description than the old term anoxic insult. Cerebral ischemia, the brain doesn't get enough oxygen for various reasons, and that causes injury to the brain. And then infections such as the damage that you would see from a patient having meningitis. Besides the penetrating trauma, we're going to talk about a specific type of closed head injury, coup contra coup injury. Do I have a picture? No, I don't have a picture. The head impacts a hard surface. So that would be, if you remember back to mechanisms of injury, you have primary collision, car hits another car, or hits a brick wall. Let's just use a brick wall. Car hits a brick wall, that's collision one. Collision two, head hits windshield. Because the head hits windshield, we have an abrupt stop in that forward motion, and that allows the brain to compress against the backside of the frontal skull, and then it rebounds as the head hits the headrest, and that moves the brain the other direction, and then you have that impact. So coup, contra coup, or counter coup is simply the brain sloshing around in the skull and causing injury to the brain. Intracranial pressure. This slide is from my advanced class. I gave you the improper range of intracranial pressure a minute ago, 5 to 15 millimeters mercury. I gave you intracranial pressure in centimeters of water, and that is the wrong measure. As intracranial pressure increases, that decreases blood flow to the brain, which is called cerebral perfusion pressure. There is a whole formula there for calculating it. You don't have to worry about that until paramedic school, and There's one thing in there that we can't calculate. We don't know what pre-hospitally what that intracranial pressure is. So we can't even work this formula. I always tell my advanced students to just plug in 15 for the ICP and calculate it from there. As intracranial pressure increases, that causes eventually pressure because of brainstem herniation. That pressure on the brainstem causes breathing patterns such as Shane Stokes respirations. If you remember that pattern from neurologic emergencies, and then Biot's respiration is another one. What else do we see? We see decrease in heart rate, high likelihood of a headache, nausea, vomiting, uh, decreasing alertness, so the level of consciousness declines, and eventually bradycardia and sluggish pupils and non-reactive pupils, posturing, and Cushing's reflex. We'll talk about Cushing's triad in a minute. Here are those breathing patterns that I mentioned. Shane Stokes, you have shallow respirations that get deeper. See that go up. It gets that those peaks get higher and higher. That represents deeper and deeper respirations, and then those peaks get more and more shallow till there's a period of apnea. Then patient does that again. So that is Shane Stokes respirations. Biot's breathing, it's clusters of rapid respirations with interspersing periods of apnea. What is the difference? Those peaks are the same size, so the depth of those respirations is the same, followed by that flat line there. That's apnea. That is not breathing at all. And then the patient does that again. We're going to go 5 more minutes and we're going to take a break. This represents damage to the medulla oblongata, by the way. This is you have this slide in the material that is available through Blackboard. We're not going to worry about it right now. Again, it's from the advanced class. Intracranial bleeding, that blood inside the skull. That skull is tough, especially if it's mine. I have a hard head. It's not going anywhere. So that bleeding increases that intracranial pressure. Bleeding can occur between the skull and the dura mater. It can occur beneath the dura mater, but outside the brain. I just mentioned a subdural hematoma, below the dura, and then within the brain itself. Epidural hematoma, that is an accumulation between the, oh good Lord, I lost my place, the skull and the arachnoid mater. I mentioned a moment ago that skull fracture in the temporal skull. The example I used was impact with the baseball, hard punch to that. The bone is more thin there, and that impact can cause this middle meningeal artery here to bleed and result in that hematoma that eventually increases the intracranial pressure, which can cause eventual brainstem herniation, we call it. I have a good video, good graphic of that in a minute. And that increasing cerebral perfusion pressure, that pressure within the brain that allows or doesn't allow, depending on the pressure, blood to circulate to the brain. uh, as as that pressure goes up, perfusion of the brain goes down. Okay, here's a picture of that epidural hematoma, uh, subdural hematoma. You'll note that the epidural hematoma is in red, subdural is in blue. In your book, the red represents oxygenated blood, such as blood within an artery, and blue represents deoxygenated blood, as in with a vein. If we remember our soft tissue injuries, arteries bleed faster than veins because arteries are under pressure. So it stands to reason that with that injury to the middle meningeal artery, that's going to bleed faster. You're going to have that accumulation of blood that compresses the brain. That's going to come about faster with more significant compression. So we're going to see signs and symptoms develop faster with that. Subdural, that's venous bleeding, that's going to come about slowly. This is an MRI of an epidural hematoma, and you can see what a big area of this is whited out, and that whited out area represents blood. This line down the middle, that should extend all the way through. It's that fibrous layer that separates the right hemisphere from the left hemisphere. And here, that there's so much compression that midline, we call it, is shifted way over. We're going to have some serious signs and symptoms with this patient, if this patient makes it at all. Subdural, that comes about more slowly. It spreads over a larger period. Uh, these are ventricles within the brain, and you see that midline is at least closer to midline. I think there might be some shift there. That's skull. I was showing you the wrong side. See, that is subdural there, accumulated around the brain and compressing the brain. Let's take a 5-minute break and come back and knock out intracranial pressure and finish out this part of the chapter. Subdural hematoma, that increases intracranial pressure because of accumulation of blood beneath the dura mater on the outside of the brain. The dura mater is a really tough layer. It's right there on the underside on the top of the brain, on the underside of the skull. There's no room for expansion toward the outside as that venous blood accumulates, and that starts to increase pressure and compress brain tissue, and that starts to cause specific signs and symptoms depending on where that subdural hematoma is. There might or might not be a skull fracture accompanying that. Intracerebral hematoma, that is bleeding within the brain itself, that and that causes compression of brain tissue and causes, through another mechanism, it causes increased intracranial pressure. Also, you have bleeding within the brain, so we're losing, if it is an arterial rupture, we're losing the supply of oxygenated blood to a portion of the brain. If it's venous, then we're going to have compression of tissue that's going to impair circulation and perfusion to that particular area of the brain. Again, back to the middle meningeal artery involved in a subarachnoid hemorrhage. We saw that slide with the picture of the skull fracture to the temporal skull. You could see that little artery extending, and that uh, that rupture of that artery causes arterial bleeding uh, above the brain that compresses brain tissue. This doesn't only happen from trauma. Someone can have an aneurysm. They can have a CVA that uh, that or a stroke that ruptured aneurysm in that middle meningeal artery, and you're going to see the same signs and symptoms. Uh, Usually, with that ruptured aneurysm, if your patient is still able to speak, or if a family member or a friend or a bystander was there, they may describe the just a sudden onset of the worst headache they've ever had in their lives. Remember, we call that a hemorrhagic stroke as opposed to the blockage type of stroke, which would be an ischemic stroke, also called a thrombolytic stroke. Okay, brainstem herniation. I've mentioned it several times. Let's look at what really is happening. This is an MRI, a lateral MRI of a normal brain over here. We can see that the cerebellum down here, remember that's responsible for coordinated movements and balance. The cerebellum is nestled underneath the occipital lobe in its normal place. Everything is cool. Everything's working great. The foramen magnum is right here in this patient. Then we see what happens as ICP increases. Intracranial pressure, for whatever reason, is going up, continues to increase, and eventually that increase in pressure forces the cerebellum over here. This is the cerebellum. It forces this tail end of the cerebellum downward, and see how this right there, it forces it down through the foramen magnum, and it puts pressure on the brainstem. And we'll talk about the physiological changes that go with that in a couple of slides. Okay, we've already this is depicted as the normal anatomy of the brain, exactly what I just showed you right there. That's normal anatomy. I'm not going to make you memorize all the names of these parts. This isn't an anatomy class. Over here, uh, well, I'll talk about that on this slide. Okay, I'm talking to myself. Sorry about that. Here we have an epidural hematoma to the frontal skull. That compresses the brain, and that compression of the brain raises the intracranial pressure. Remember, I said that as ICP goes up, just from normal life, bending over to tie your shoes, getting your head lower than your waist, those sorts of things, that increases ICP, and the body compensates by displacing cerebrospinal fluid down from the fourth ventricle in the brain down through the cisterns around the brainstem and down along the outside of the brainstem in order to maintain that normal intracranial pressure. With this herniated brainstem here, besides affecting the respiratory center, this compression compounds the increased intracranial pressure because it compresses those cisterns so that CSF can't be displaced down around the circumferentially around the outside of the spinal cord, and that makes ICP go up even more, and that compression and increased ICP continues to push more of the brainstem down through here, and that compresses, or more of the cerebellum, compresses and pushes more of the cerebellum down through the foramen magnum and causes further compression of the brainstem. So let's move on. Talk about herniating the brainstem, the herniation syndrome. The brain is forced downward, CSF flow is obstructed, and because of pressure on the brainstem. What does that do to level of consciousness? That causes decreasing level of consciousness, eventually rapidly decreasing level of consciousness, and that decreasing level of consciousness progresses to coma. What is coma? That is when our patients don't wake up. They don't return to consciousness. They're unconscious, unresponsive, and stay there. Other associated symptoms, some new terms here, ipsilateral and contralateral. Ipsilateral means on the same side of midline. Contralateral means on the other side. So let's see, what would be an example of that? Let's say our patient is impaled from behind with a piece of 3/8 inch rebar, and it enters the thoracic cavity just under the right scapula, and then we have exit below the contralateral nipple. What would that mean? Good grief, he's using big words. I'm getting you ready for paramedic school. We're professional clinicians. We have to learn to speak as such. I don't do that all the time. I get lazy. But what does that mean? That means that big piece of rebar went in below the right scapula. It went at an angle through the chest, and it came out just below the left nipple. That would be entrance with a contralateral exit. Let's say the same entrance wound, our patient's impaled on 3/8 rebar, but exit is 1 centimeter inferior to the ipsilateral nipple. Entrance was below the right scapula, and exit was just below the right nipple. Which is worse for our patient? I would say that entrance on the right, exit on the left, right? We involve more tissue. The heart sits right there. It could be involved. So that's all ipsilateral and contralateral are. All that to say ipsilateral pupil dilation. We have pupil dilation on the same side as the lesion or the accumulation of blood that's compressing and causing the herniation of the brainstem, and contralateral paralysis. That muscle movement that crosses the midline so that the right side of the brain controls the left side of the body. So we have that injury to the brain, compression of the brain on the right that causes muscle problems on the left. So you would have, if the injury is to the right side of the brain, you would have dilation of the right pupil, but muscle impairment on the left side, and then decerebrate posturing. The way to remember decerebrate posturing is to think of it as the opposite of decorticate. Decorticate, the hands move in toward the core while the toes point down and out, and this is a very bad sign to have decorticate posturing. Decerebrate posturing, the hands turn outward like that, usually with thumb between the middle and ring finger for some reason. Sometimes between, or usually with the thumb between the index finger and middle finger. Sometimes it's between the middle finger and the ring finger. Most of the time it's going to be like this. Not that that really matters to you, but it turns outward and down by the sides. So that's the cerebrate posturing, and decorticate posturing is toward the center. Decerebrate involves the cerebral cortex, and that is worse. Okay, and then as it progresses, you have that irregular respiratory pattern that we looked at earlier, eventually progressing to respiratory arrest and death of our patient. Cushing's triad. As ICP increases and we see that brainstem herniation that we've been talking about ad nauseum, meaning to the point you want to puke. You just learned some Latin too. Cushing's triad, ICP goes up, brainstem starts to herniate. If you've learned what vital signs do in hemorrhagic shock, compensated hemorrhagic shock, or no, excuse me, not compensated. If you've learned how vital signs behave in shock, then think of it as the opposite. So systolic blood pressure goes up, pulse rate goes down, the patient's becoming bradycardic. Bradycardic in an adult is a heart rate less than 60, and then respirations go down. So eventually that patient's going to be apneic. So that is Cushing's triad. Those are clinical signs of brainstem herniation, and that's going to trigger specific treatment that I'll show you in a moment. Okay, concussion, blow to the head that causes temporary loss of the brain's ability to function without permanent damage to the brain. Only about 10% of patients with concussion lose consciousness. That's maybe different than what my coaches thought when I was in school. Patient with concussion, frequently you see confusion. You may see amnesia. Amnesia being the loss of memory. If it's retrograde amnesia, they lose their memory of events leading up to the injury. So they lose a block of time. They may not remember, if they, let's say if it's football and they're injured in the early fourth quarter, they get a concussion. They may not remember going to the locker room at halftime. Sometimes they don't even remember that they played in a football game. That's retrograde amnesia. They don't remember the events leading up to the ball game Concussions have a short duration. There can be catastrophic results in patients who aren't allowed to heal after a concussion and suffer a second concussion. We'll talk about that in a minute. Symptoms of a concussion: dizziness, weakness, visual changes, see flashing lights, see floaters, that kind of thing. Nausea, possibly vomiting, tinnitus or ringing in the ears, slurred speech, inability to focus. That could be confused with somebody being drunk, right? Drunks get concussions too. Doesn't have to be a drunk. Somebody could have a drink and then somebody hits them in the head and they have a concussion, and then they're accused of being severely intoxicated when in truth they have a concussion. Uh, if you suspect a concussion because your patient presents with these symptoms, we need to ask about these symptoms. Lack of coordination. If you go to football games now, high school football games, before they got the little tent where they take somebody in to evaluate them so we can't all watch, you would see a trainer holding a finger up like this and asking the person to reach out and touch the finger, person who is suspected of having a concussion, or asking them to reach up and touch their nose. That displays coordination or lack of coordination, delayed motor functions, inappropriate emotional responses, inexplicably happy or inexplicably sad when it should be really happy, temporary headache, disorientation. Contusion is worse. Contusion causes physical injury to brain tissue. That could even cause permanent damage to the brain. Patient can experience all those signs that we've talked about with other brain injury, or with previous brain injuries we've talked about. I'm reading ahead on the slides. The other brain injuries, blood clots, hemorrhages. We had a whole chapter on that back before spring break. Uh, Signs and symptoms of those, you have signs and symptoms of traumatic brain injury where there's no obvious mechanism of injury, there's no external evidence of trauma. We're dealing more with a nature of illness situation, but with the same patient presentation. Compression injuries, okay. So that gets us through brain injuries. Actually, I'm just going to keep going. I'm not going to split this into two recordings. We just need to keep going and not waste 10 minutes. Okay, compression injuries of the spine. Let's use the example of a car accident, so that maybe the person the occupant has on a lap belt and they're thrown forward in their seat, just like I just got closer to the camera there. That's a horrible sight, right? Uh, and that stretches out the spine. Or little girl with the ponytail falls from way up in the tree she climbed, and her hair gets her long ponytail gets caught in the branches and overextends the spine. Uh, in a rollover accident, you have rotational flexion injuries. You have in the rollover, you have the head being jostled around, stretching the neck in ways it's not supposed to go. Uh, that can also cause fractures. That stretching can. Those are not natural ways of motion and cause everything from soft tissue injuries, as in a whiplash type injury, to fractures of vertebral bodies and bone fragments being impaled into spinal cord. In our patient assessment, we're always going to have a high index of suspicion with these mechanisms of injury to our patients. Motor vehicle collisions, particularly unrestrained occupants in a motor vehicle collision or who stay inside the vehicle, or unrestrained occupants in an MVC that result in the patient being ejected from the vehicle. Pedestrian motor vehicle collisions, car peds, that's what we always called them, falls, blunt trauma to the head, uh, blunt trauma to the neck, the back, the torso. We need to have a high index of suspicion of spinal injuries. We need to assess for those. Others, rapid deceleration injuries, hangings. For some reason, in my years working in the field, I was the king of hangings. If there was going to be a hanging or two hangings on a shift, I was the guy who ran the call. I ran more hangings than I could count. Those don't always result in spinal injuries. Sometimes hanging results in death by asphyxiation because of constriction of the trachea. And they just hang there and suffocate. And then axial loading injuries, uh, diving injuries uh, into a swimming pool or into a lake and dive and hit the top of the head and compress the spine. That can result in possible head injuries, spinal injuries. Uh, that's still axial loading. Another axial loading injury that could cause a spinal cord injury would be fall from a height, landing on the heels, and that transmits that force up the legs, up through the pelvis and into the spine. And if it's fall from enough of a height, that could cause spinal fractures. Could even be enough of an impact, I guess, to maybe cause head injury. I've never read of that or heard of that, but doesn't mean it hasn't happened. Going to get a history. We need to investigate chief complaint. Uh, what is our patient's chief complaint? Just seems confused. Grandpa came over to see Grandpa this morning on my way to work. I brought him dinner last night. He was fine. This morning he's all confused, and it looks like he has has big bruises all over his his arm, and he's all confused. Why are you looking at his head? Why are you feeling his head? I'm feeling to see if he hit his head when he fell. That's that happens very frequently. Elderly patients with falls, we always want to uh, consider who are confused. We always want to consider that they might have a closed head injury, and uh, and then we use our our acronyms, OPQRST. We're going to gather as much sample history as we can. Uh, Glasgow Coma Scale, be familiar with that. I'm going to make you memorize it when you get to my trauma class in paramedic school. Right now, I want you to know that Glasgow Coma Scale it's used to determine uh, mental function in our patients, uh, and uh, beginning with eye opening. When we walk up, do they just open their eyes and look at us spontaneously, or do we have to, or do they have no response? And in between there, do they look at us when we speak to them? They open their eyes when we speak to them, or do they only open their eyes in response to pain? Oriented conversation, we get a 5. So This follows a pattern I like, 4, 5, 6. The best you can get is 15. 3 is the worst you can have. This desk that I have my hand resting on has a GCS of 3, I guess. It's not doing anything. It's just sitting there. Uh, and hopefully I have a GCS of 15 talking to you. Be familiar with that. It's an excellent tool in assessing the progression uh, of changes to our patients with head trauma. As let's say our patient has a brain bleed from a closed head injury. As intracranial pressure goes up from that slow bleed, let's say it's a subdural that's developing, then as level of consciousness goes down, we're also going to be able to watch changes in the GCS. We're going to treat that as a vital sign, and as we're trending vitals, every time we reassess our patient, we're going to note what their GCS is, so we can track changes in their level of consciousness. Care of head trauma. We have to take care of that airway. We have to manage the airway. Remember, if our patient has facial trauma, that is a relative contraindication for the use of a nasopharyngeal airway. So airway adjuncts, hopefully we're going to be able to use an OPA if they will tolerate that to provide an airway. Control bleeding. If we have bleeding from the nose or ears, we're gonna treat that as if we have a basilar skull fracture, and treat that as if we have CSF in that. We don't want to stop that flow. That flow is helping to decrease intracranial pressure, and that's helping to maintain cerebral perfusion. Other things we do to maintain cerebral perfusion, if necessary, we do CPR, and then to protect ourselves, we observe standard precautions. We need to get a baseline set of vitals and a baseline level of consciousness, and then we need to continuously monitor that. The tool that we use to track changes in that level of consciousness and changes in brain function would be that Glasgow Coma Scale. And if our patient has a sudden loss of consciousness, we need to go back to the primary survey. Do they still have an airway? Do they still have breathing? Okay, we feel a little bit better. Now they have a loss of consciousness. We need to find out what happened, get another set of vitals, and then repeat the pertinent parts of our secondary survey to try to determine what the problem is. We're going to use the jaw thrust maneuver to open our patient's airway. If that absolutely will not work, you could use the head tilt chin lift method, but that's your last ditch shot at getting an airway, and you need to document that extremely well. Once you have an airway, we need to maintain cervical spine in a neutral position, get a cervical collar on, secure that patient to a backboard and then have a cervical immobilization device, have that patient strapped down so that we can raise the head of that backboard. That means hold the backboard up, prop stuff under it. That helps hopefully drain some of that CSF down along those channels around the spinal cord to help lower intracranial pressure. All right. Same old airway management, but we're going to talk through it real quick. I'm going to go fast because you already know this stuff. Remove foreign bodies from the mouth, suction secretions out, suction vomitus out. If we have a patient with a head injury who has full spinal immobilization in place and they have nausea and vomiting, we're going to put that backboard up on the side, put blankets underneath it, and then strap that down to our stretcher, to our cot, so that if our patient vomits, they have a less likelihood of aspirating the vomit, but we need to be ready with the suction also. We're going to monitor their ventilation. We use our SpO2 monitor and our, if we have it available in tidal, CO2 monitoring is going to give us a really good idea of what's going on. We're going to give supplemental oxygen to our patients with a suspected head injury. Circulation, start CPR when they need it. We need to stop blood loss. And we need to control bleeding with direct pressure. If we need to put a tourniquet, you have a patient with multi-systems trauma and they have uncontrolled bleeding from an extremity, get a tourniquet on it. We have to treat the whole patient. And shock results from hypovolemia. Remember, we looked at Cushing's triad, and the vital signs were the opposite of what you have in a shock patient. So if your patient is in shock, and even if they have had trauma, they're in shock, we need to look for the source of the bleeding that's causing the shock. Do they have bleeding in their abdomen? Do they have bleeding in their pelvis? Do they have hemothorax from injury in their chest? We have to evaluate the whole patient, treat for shock, and then transport to the highest level of trauma center that we have available to us according to your protocols. Cushing's triad, we've talked about. We have increased ICP, we have increased blood pressure. As that brainstem herniates, we have decreased heart rate, bradycardia, we have irregular respirations. In our patients that show signs of brainstem herniation, and that would be our patients that demonstrate Cushing's triad, we want to perform controlled hyperventilation with positive pressure ventilation as EMTs. That's going to be with a bag valve mask connected to, with a reservoir bag connected to O2 supply. So we're delivering right at 100% FiO2, and we're going to ventilate them at 20 breaths per minute. That's not super fast, but that helps blow off more carbon dioxide. And by blowing off more carbon dioxide, we're going to start to help decrease the intracranial pressure of our patients. So that's why we perform controlled hyperventilation. That is the only time we hyperventilate a patient with a closed head injury. So remember, Cushing's triad, they have to demonstrate that. That is a sign of brainstem herniation, and that is how we treat it. Follow standard precautions. We should do that from the very beginning. This is in spinal injury. Okay, we are protecting ourselves first. Medical treatment of spinal injuries. Follow standard precautions. We have to protect ourselves, right? Maintain the patient's airway. We're going to maintain proper positioning of the head. We'll use the head tilt chin lift method and provide that airway. Use an airway adjunct such as an NPA or an OPA if needed. And then we're going to provide supplemental oxygen via the appropriate device. That may be a non-rebreather mask. That may be a bag valve mask, depending on whether our patient has sufficient breathing or not. After we open the airway, consider that airway adjunct Uh, always have suctioning available. Anytime you're managing an airway, have suctioning available. That doesn't mean that you have the portable suction unit out of the cabinet and sitting on the floor and suction tubing still in its factory packaging and your uh, your tonsil tip suction still in its factory packaging. Suction unit suctioning available. I mean, you have it all put together so that all you have to do is hit a button and start suctioning your patient, and then provide appropriate level of supplemental oxygen. That's jaw thrust there. Uh, that's what I meant to say earlier about opening the airway was with the jaw thrust. Head tilt chin lift is kind of your last ditch effort at opening the airway. Well, I screwed that up, but we learned something from it, right? If Buddy sees the pictures, he eventually gets the treatment correct. So backing up, we're not going to use the head tilt chin lift method unless everything else fails. We're going to use the jaw thrust to open our patient's airway. We're going to immobilize the spine. We're going to and immobilize the spine. That's complete spinal immobilization. So that's a cervical collar, and then log roll the patient onto the backboard, and then place the CID in place, uh, and secure the head to the CID and the CID to the backboard, and then we're going to have the backboard straps on the patient. So that's full spinal immobilization. You may have a protocol. Let's say that uh, because backboards are falling out of favor and we are moving toward immobilizing the cervical spine and then placing the patient on the cot. So follow what your protocol is, but if you suspect a spinal injury, you are going to fully immobilize that patient. If it's prophylactic application, maybe they might have a spinal injury, or they've been in a car wreck and they don't have neck pain and they don't have any signs and symptoms of spinal injury, then you may see that patient today placed directly on the stretcher and belted in for the ride, whereas 10 years ago, that same patient would have full spinal immobilization. So those changes are slow to come about. They're backed by research. They freak old people like me out. That is abnormal in my world, but I am changing. You can teach an old dog new tricks. It just takes longer and you have to use better treats. I guess better treats for me is my paycheck at the college, right? And continue licensure. That's important. Cervical collars. We've used them in lab. You know how to use a cervical collar. You know how to measure. You know how to apply that. You know that the person who first grabs C-spine or initiates manual spinal immobilization, they don't release that manual spinal immobilization. So you have the cervical collar and backboard and CID in place. That patient's fully secured to the backboard. Then you don't have anything to do with your hands anymore. Or Talladega Nights, Ricky Bobby, what do I do with my hands? Don't have anything to do with them anymore. You have your patient secure, and you can release C-spine up there. One note about cervical collars, since we're talking about head injuries today, also research also shows that cervical collars increase intracranial pressure. So that is a significant thing. Uh, that's another reason to prop the head of the backboard up if you think that your patient has increased ICP and your you're even prophylactically utilizing full spinal immobilization, that can exacerbate or make worse the problem of increasing intracranial pressure. Uh, Other ways you can use a vacuum mattress. We don't see those. Those cost a lot of money, and you get your patient to the hospital, and somebody decides it's a great idea to take your beautiful vacuum mattress that you rolled your patient onto, you folded it up with straps, and you sucked all the air out of it, and it conformed to every crease and crevice of your patient, and they are perfectly immobilized, and you get to the hospital, and you leave your patient, and after they've done spinal x-rays and cleared C-spine and cleared thoracic spine, then they take their scissors and they cut your $600 vacuum mattress off. So you don't see those used a whole lot. Okay, remember we use a 4-person log roll to log roll our patient on the backboard. Person at the head is in control of all moves. So the person holding C-spine says, we're going to log roll toward you on 3, to log roll to the patient's left on 3, 1, 2, 3. Then the question becomes, do we log roll on when I say 3 or after I say 3? That's the ongoing thing. It pays to work with the crew all the time so everybody knows what the other one's doing. That's why we practice, so we don't screw things like that up. Sounds funny right now thinking about it. It's 1, 2, and I'm thinking I'm going to say 3, and then I'm going to log roll. I'm at the head, and the 3 people who are going to log roll my patient think as the word 3 is said, they roll the patient. So it's 1, 2, 3, and boom, there went my patient. I'm not a chiropractor popping a neck. I'm still sitting here, hold the head, and coming right behind that the rest of the patient that rolled without me moving the head with them. So it pays if you're with a new crew or you have a fire crew that you're not used to running with. Say we're gonna roll. We're gonna log roll on 3. I'm gonna say 3, and then we roll. Or as soon as I say 3, we're gonna log roll the patient. Whatever you need to do to communicate that. Communicate. Make sure everybody's on the same page. Vacuum mattress, they're great. We would all use that if we could, but they're expensive. That's a vacuum mattress. That's what it looks like. And you suck the air out. Look, you have handles on your patient. You could flip them over and hold them face down. They would still be fully immobilized. Seated patients, we're going to take them, put that short spine board on. If we have a critical patient, we're not going to put the green KED or short board on them. We're going to do a rapid extrication. We're going to maintain spinal immobilization. We're going to maintain the spine in line, and we're going to rotate that patient and then lay them down on the backboard. But if we don't have a critical patient, we could secure them to the short board. Then we could rotate them out onto the long board and secure them to the long board with the short board in place. Remember, after you place your patient in a supine position using that green thing, we're going to pop the thigh straps because it hurts to lay there with those straps squeezing up into you. It serves no purpose at that point. Okay. Standing patients, we do standing takedown. We used to teach that in lab all the time. It's rarely ever done. That's how it's done. When do we do it? Have a patient with potential spinal injury, and so we apply manual cervical immobilization in the standing position, get a C-collar on, get the backboard crammed in behind them. We get them strapped to the backboard, and then we lay them down. You could also use Never mind. I thought that looked like a scoop stretcher for a second. Spinal immobilization devices. Uh, there are scoop stretchers out there. Those don't immobilize as well as a long spine board does. Uh, and proper spinal immobilization is going to involve a C-collar, a backboard, and a cervical immobilization device, or sandbags and tape. Sandbags, prop those uh, cylindrical sandbags. Some of them are about 10 inches to a foot long, and maybe 3 inches, 4 inches wide, and 3 inches tall, something like that. And you block those in beside the patient's head, and then you can use tape to secure their head to the long spine board, or you can have the commercial cervical immobilization device. That's most likely what you're going to have these days. Know that those dang sandbags are still out there. You've used this thing, you know what the KED is for, you know how to use it. You have used that long spine board right there. Helmets. A well-fitting helmet is another line of protection to hopefully prevent or minimize uh, head injuries in motorcycle accidents, race car accidents, in football collisions, all of those things, and utilize helmets to help provide more protection to our patient's head, or hopefully keep them from even being a patient after the impact. That's even better. We're not going to remove a helmet unless it's impeding the airway or our patient has breathing problems. We can assess our patient with that in there. With the helmet on, with the helmet and shoulder pads on for a football player, you might not have to pad under the shoulders. Uh, if you take the helmet off, also take the shoulder pads off with a football injury. Motorcycle helmet, you can leave that in place. Not a full face helmet, but just a regular old motorcycle helmet, which you see very few of these days. That full face helmet, we're going to have to get the helmet off. Normally, we would demonstrate that in lab today or in our next lab after today. We do not have that advantage. Remind me when you get to paramedic school or advanced EMT school. I will teach you how to and let you practice properly removing a helmet from a patient. In the meantime, go out and watch some YouTube videos of helmet removal. I think it would be time well spent after you get through studying for the next go around. Another time is if that helmet interferes with proper spinal immobilization, or if it's allowing excessive head movement. If our patient goes into cardiac arrest, that helmet needs to be gone. We need to be able to fully manage our patient in cardiac arrest. It's a two-person job. One person sticks fingers up in under the pads of the helmet and maintains spinal immobilization that way, and then the helmet is removed. That would be one way to do it, with working from the patient's front, reaching up under. If it's a football helmet, uh, you may have noticed this at football games before, or maybe I'm the only one who notices it, but face masks on football helmets, for the most part now, have a loop and screw system, and the screws hold these loops that hold the face mask to the football helmet, and you can take a power screwdriver and remove those screws and get that face mask out of the way, and then it makes it easier to remove the helmet. Move chin strap, move face mask, Pop the jaw pads out of place. This isn't a motorcycle helmet, by the way, because I don't think on most helmets that those jaw pads pop out. Place your fingers in the helmet, hold the jaw with part of your hand and the occiput with the other part of the hand. If your hands are small, that may be harder. Uh, and then slide the helmet off, put padding behind your patient's occiput, like so. Uh, Over here, he's unscrewing the face mask of the football player. Okay, we're almost done, folks. Another another diagram of helmet removal, and that is the end of that chapter.